is the first symposium on how do you manage. And may I invite Dr. Ravichandran, one of my mentors, from Chennai, Dr. Jai Kumar, Dr. Amit Gupta from Lucknow, Dr. Suvarnalata Guditi from Hyderabad, Dr. Sampath Kumar, I didn't say, yes, Dr. Anurag Gupta, and Dr. Vivek Pathak. Since Dr. Suvarnalata Guditi has to leave early, may we ask her to be the first of the two chairpersons to take the first talk on ABO incompatibility or ABO incompatible transplant, blood group, high titers, how do we conquer the higher titers? And to talk on it is Dr. Aakash Shingada from Mumbai. He's the guy who's my partner and who wants me to leave a little more for him.
No, I did not finish the comment. It's about experimenting, sir. It's about experimenting life.
Doctor,
what you will do is by just experimenting for.
Dr. Aakash Shingada will talk to us on ABO incompatible transplant, and he's got a good experience from Gangaram, and he continues to do it along with us at the Kidney Associates Private Limited, our partnership firm, our company. Yes, over to Aakash, you start, and then the chairpersons will take over the discussions.
One of the benefits of group practice that you stand on this stage in front of this august audience with is because you are in good practice with Dr. Umesh Khanna, that you're standing, in front of a lot of teachers who've taught me how to do transplants, and I may still not be doing it well. So pardon me if I make a mistake. And with that, I begin my talk. There's not much new in this field. We all know more or less everything that's currently being done. And I'll try and rush through the slides because the bigger challenge rather than, will be to finish it in 10 minutes. So to do or not to do is the first point. And how do we define these high titers? Are they 1:64, 1:128? There's no standard definition, but multiple studies have used different cutoffs. More than 1:128 or 256 may be considered high baseline titer. And, that's what the studies have currently used in their analysis. Studies have compared high versus low baseline agglutinin titers and their effects on outcomes. There were two trials from, by Chung et al. And they were just kind of initial observational studies which suggested that high titer ABO incompatible transplants were possible. I just would like to share our study from Gangaram Hospital, which was led by my colleague Lavi. She's not there today, unfortunately. And this was a retrospective analysis of more than 900 transplants, of which approximately 67 belong to the low, 800 odd belong to ABO compatible group, 67 belong to low titer, and approximately 17 belong to high titer group. And we saw in this study that there were decent graft outcomes in the high titer ABO incompatible groups as well. However, there were definitely significantly higher antibody mediated rejections in the high titer ABO incompatible groups, along with some infections. So before, this has to be a case-based talk. So let's begin with the case. This was a 23-year-old male, very early in my career. CKD5 on dialysis 3 times a week since 2 years. Prospective donor being mother, she was 48. It was a B2O positive transplant. Again, a difficult thing to go for a swap. Baseline titers being 1:5 and 2. PKD was attempted. There was a long wait time. This was during COVID that this was happening, so we were not too keen to take him for a transplant at that point of time. And he was on dialysis for 2 years and very eager to go for the kidney transplant. His titer was later rechecked when we decided to take the plunge, and unfortunately turned up to be 1:2046. He had a recent history of COVID infection. This was likely an anamnestic antibody response. The titer was rechecked after about a month. It had come down to 1:024, and after legal process and authorization committee clearance, it was planned to take him, for desensitization. We gave him a Ritux of 200 milligrams at day -28. This was not a planned day -28. It was a day -14 planned Ritux. However, there was some, personal challenges in his house because of which the subsequent protocol got delayed. At day -14, he was started on TAC and MMF. Day -8 titers were 512. They had come down from 1024. This was a little surprising for us, but it had come down. And we started therapeutic plasma exchanges with approximately 1.5 plasma volume. And we did 3 consecutive plasma pheresis, and the titers had come down to 1:64. At this point of time, immunoadsorption was contemplated, but he was extremely poor. He had just recently started driving and was just barely making 15,000 rupees a month. So we decided to pull on. We were doing a lot of NGOs were helping to help this person. And we did 2 more plasma pheresis, but this time with half volume replacement with donor group FFPs. At day -1, the titer was 1:8 and the patient was transplanted. Post-op, the titer rebounded to 1:16, but remained steady there and then reduced thereafter. There was no graft dysfunction. And today, 9 months post-kidney transplant, his creatinine ranges between 0.9 to 1 milligrams per deciliter. The key points here were that, like popular protocols, we did not use IVIG. Unlike popular protocols, we did not use IVIG. We used donor FFPs as replacement fluid towards the end of our desensitization protocol. And the other question is, should immunoadsorption have been used a bit earlier? And the main limiting factor here was cost, which is more often than not the case every time. And with antibody removal process being the major source of expenditure, accounting for 90% of the cost difference between compatible and incompatible transplants. So with the different options available, ultimately it's upon us to choose the most cost-effective technique, because given the best case scenario, we would probably do the best that is there. So how do we approach a prospective ABO incompatible kidney transplant with high titer? So the most important thing that we saw in this case also, we rule out any active recent infection, immunization, an episode of CRBSI, a recent vaccination, or a recent viral illness, to rule out a possibility of an anamnestic antibody response. If you see a titer of 1:2000, should recheck in 2 weeks to see whether it's come down or not. Attempt definitely paired kidney donation. And ultimately, when the wait times keep increasing and the patient, there are desperate times, we go with either choice of technique, whether it's therapeutic plasma exchange or immunoadsorption, considering the cost effectiveness of these modalities. Now, talking about the problem with most high titer transplants is rebound titers. Now, rebound titers occur either due to production of new antibodies by plasma cells and B cells, hence the need to start immunosuppression prior to plasmapheresis. Equilibrium from extra to intravascular compartment, as only 45% of IgG is intravascular, hence repeated exchanges are required. And factors which affect rebound are baseline titers. High titers are associated with greater rebound, and time from rituximab to transplant. If you time the rituximab closer to the transplant, the chances of rebound are a little higher. And are these the only possible causes for persistent high titers or rebound? Let's talk about IVIG. It is made from pooled plasma of donors that include donors from various blood groups. Hence, IVIG will also contain anti-blood group antibodies. And most desensitization protocols use IVIG, either in low dose or high dose, especially post-plasmapheresis. And the impact of these anti-blood group antibodies on rebound is not very well described. The variability of anti-blood group antibodies in different IVIG products of the same brand but different batches is also unknown. There was a trial from Delhi, Dr. Khair's group. They studied this in a particular case, and they analyzed the antibody titers in the IVIG bottles of different brands of different batches, and they saw great heterogeneity with titers in the IVIG ranging from 1:8 to 1:512. So this it may impact the rebound titers that we see or the persistent high titers that we see when we are treating these patients. Whether they do affect the clinical outcomes or not is we are completely unsure of it, but they definitely interfere with decision making. And either the patient gets delayed, they undergoes more plasmapheresis than what is needed, and may even get cancelled from a kidney transplant. So it's recommended that all centers doing ABO incompatible transplant should use IVIG products and lots that have tested low anti-AB titers. Transplant centers may do this on their own. And the other option is to perform ABO incompatible transplant without IVIG, especially when using specific anti-AB immunoadsorption columns. So having finished that, we come to the principles of modern desensitization regimens. I'm way past my time limit, but this is something which everybody knows. So you briefly, rapidly rushing through it, with reduction, the first step is reduction of B lymphocyte pool. Splenectomy now being obsolete. Rituximab nowadays we're trying to reduce the dose that we're planning, that we're giving to these patients. Initially, high titer patients had received 2 doses of rituximab. From there, it came down to 500. From there, it came down to 200. Nowadays, we're using 100 milligrams of rituximab also, and it's being equally efficacious. There were a few reports of using bortezomib for titers which were more than 1:1024. However, there is not enough data to draw any conclusion. Coming to antibody removing techniques, there can be, non-specific plasmapheresis or more specific immunoadsorption techniques which removes specific IgG, IgM, and with replacement fluid options being albumin versus donor FFPs. Now, this is a little interesting because, why donor FFPs? Because most of, as it's very well known, FFPs do contain blood group antigens, and these are called as soluble ABO group substances. They can help us in neutralizing the blood group antibodies. So if they are given as replacement fluids, they may help achieve better responses, better antibody responses. During desensitized protocols. And this is not just a conceptual statement. There have been, studies which have kind of looked at it. And this one from Korea, where they study the benefits of fresh frozen plasma as a replacement fluid to neutralize ABO antibodies. And they saw that the ABO antibody levels were reduced more effectively by group AB FFPs than by albumin. And either group AB or donor type FFPs can be infused to group O recipients, especially in difficult to reduce control titer patients. This was duplicated in multiple other trials. Again, this one from Japan. And here they also suggested that there was a more significant decrease of isoagglutinin titers in the FFP group compared to the albumin group. Now, comparing the 3 different modalities of antibody removal, I don't think I have time to talk in detail about this. We all know the benefit of immunoadsorption over non-specific plasmapheresis. It's supposed to be the best, when it comes to removing the antibody titers. But the challenge here is cost. Why are we not using immunoadsorption? It's probably the cost only, which is precluding. Otherwise, we would go for immunoadsorption in every case. So many a times you require multiple sessions of immunoadsorption. You have to use the immunoadsorption multiple times. So that becomes extremely difficult. However, this study from the Swiss group by Scheisser's group suggested that the immunoadsorption column, which otherwise the company suggests to be used only once, had reused it multiple times. And this was duplicated by the India, we also did it in India, Dr. Khair's group again, where they did it for a difficult case. And they reused the same IA column 3 more times. And the method for reuse that was recommended by the Swiss group was a little complex. However, our group came up with a more simpler method of reuse by rinsing with just 1000 ml of saline and sterilizing with ethylene oxide and stored in the dark at 2 to 8 degrees Celsius. And this showed a good benefit and good response. Last 2 to 3 slides, sir. I'll just rush through it. So, when we talk about cost effectiveness, this was an Indian working group recommendation that to reach a titer of less than 1:16, if you start at 32, the approximate number of plasma exchanges would be 2, 3, 4 as the titers keep on increasing. And they analyzed that if you needed more than 4 sessions of therapeutic plasmapheresis, it would end up being cost ineffective versus if you just used immunoabsorption directly. So if you feel that your titers are going to be more than 1:128, you're actually not going to end up saving money if by doing 4 or 5 plasmapheresis versus if you directly go for immunoadsorption. And so summarizing what we do when we are faced with a high titer patient, we rule out an anamnestic antibody response, a recent infection. We begin the anti-B cell treatment with Ritux at least two or more weeks before the kidney transplant. Therapeutic plasma exchange without IVIG till standardization of production. We've decided to not use IVIG till there is definite work on this. And if therapeutic plasma exchanges exceed more than 4, we then use donor FFPs as replacement fluid. And if it's less than 3 log titer reduction in the first 3 therapeutic plasma exchanges, we switch to immunoadsorption. TAC MMF 7 to 14 days pre-transplant. However, in an ideal world, for titers more than 1:128, I would go with immunoadsorption to at the outset.
Thanks, Aakash. It is unfair to ask in 10 minutes to cover up these topics. but unfortunately we have 4 topics and we need about 3 to 4 minutes for discussion after each topic.
That's a very small group. Just thank you for the opportunity, sir, and Mayuri ma'am for giving me this
That's
platform.
the group practice of Kidney Associates. Yes. Please, Dr. Ravichandran, your comments.
Yeah. So,
Yeah.
yeah. So, the
Mike.
backbone of ABOi incompatible transplantation is the backbone of ABOi incompatible transplantation is desensitization. If you try to chase titers, see the titers itself varies from center to center. And when you try to chase titers to very low levels, you will land up in complications, trying to give more and more of aggressive treatment. I am always reminded of Tanabe's episode where they started at 1 in 32,000 titer, and they ultimately stopped at 1 in 2,000 and did the transplant very successfully. So it's not that this value is sacrosanct, that you should achieve this titer before transplantation. I think it is the lowering of the immune status which is more important in determining the outcome of ABOi incompatible. We have published a case series where we have used bortezomib in 4 patients, and we have been able to bring down with a couple of plasma exchanges and bortezomib very effectively the titers.
We have finished 350 ABOi incompatibles, and last month I published data on 248. What I have changed the technique is over a period of years, I have increased donor group FFP more. And what is the effect? 1, number of plasma pheresis sessions has come down. I stopped using filter completely. Whether titer is 2,000 or 8,000 or 1,000 doesn't matter anymore. Number of plasma pheresis sessions, if you don't use albumin, use only donor group FFP, has come down by almost 50 or 60%. I have not purchased filters at all. Second advantage, when you use FFP, you don't have to worry about bleeding episodes, or you don't have to check PT and PTT replace cryoprecipitate of fresh fusion plasma before transplant, because bleeding is often a concern ABOi incompatible transplant. Next advantage, I stopped using IVIG for each plasma pheresis session, which I was using before, as each liter of FFP contains 5 grams of immunoglobulin anyhow. So when you replace, suppose 3 liters of plasma exchange, I'm doing with the donor group, it doesn't cause any reactions. So I'm replacing with each gram, with each liter of 5 grams. So replacement of IVIG cost is gone. Number of plasma pheresis sessions is gone. Number of bleeding episodes is gone. You are very comfortable doing transplants. Requirement of filter is gone. The only problem is when somebody gets rejection is post-op in the first 3 days. When you do plasma pheresis, you remove Simlet also. At the time, filter may be beneficial, but for that sake, I don't want to space 3.5 lakh rupees for filter, because 5 sessions will equal to 1 filter, and even 5 and 2 comes down to say 1:8. Suppose a patient level is stable at 1:16 for 3 sessions, then I go ahead with transplant. One more thing, when your number of transplants ABOi rises more and more, you will see one more phenomena called as desensitization failure. For example, if I start with a titer of 5 and 2 or 256, I'm stuck at 64. I don't have the guts to do transplant 64, but that desensitization failure is also gone with this technique of replacing an entire filtered plasma with a donor group FP, not with albumin anymore, and reduce the number of immunosuppression faster. So that way I have encountered, I have the problem of infection I have surmounted, problem of bleeding also, cost of fluid replacement, cost of filter and IVIG. I published last month.
Dr. Vijay Kher on ABO. Yeah.
With what Ravichandran is saying, and these days now in Japan, people are transplanting ABO titers up to 128 without desensitization, and they don't use. So there are centers in Japan who don't look at titers at all. They do 4 plasma pheresis sessions without looking at titers, and then do the transplant, and they're as successful as, so they don't look at the titers at all. So I am still not sure as to what is the meaning of titers in ABO.
Would you do that?
Yes, that, no, I'm not saying
No,
that.
for a low
I'm
titer
doing-
also, sir.
What
For
I'm
a
saying
big-
is that many people are changing, these paradigms are changing. Even the Japanese who were concerned about the titers to start with, most of them are no longer concerned about titers of 32, 64 or 128 as well.
I think Jay Kumar, one short comment. Yeah. Louder. Mic. Can somebody look at the mic? I think we'll need some time for the other sessions also. So
you do with high titers, if you say that titers do not matter, what is the prevalence of ABM are following?
We are not sure. Titers may not matter. The point is desensitization is more important. That you have to lower the immune system more. The use of rituximab. There are centers who do even without rituximab. But the use of rituximab or starting the immunosuppression early, plasmapheresis with IVIG, without IVIG. So you're altering the immune system. But this titer business of having a particular value is becoming questionable.
Thank you, Ravi.
But
Thanks,
there have been
Akash.
reports that ABMR is higher if your titers are high. Benjamin.
I
Thank you.
think we have many other sessions to go, so we'll close this session and move on to the next talk. Thanks, Akash.